السلام عليكم ورحمة الله وبركاته. صبحكم الله بالخير. أنا كنت طالب أنهم يقدمونا بدري لأن إحنا الشياب نقوم بدري، كان خلوا الشباب وراء. إن شاء الله ما نطول عليكم. The ideal situation would be having a lot of money and the biologics will be cheap and available all the time and have no side effects. But this is unfortunately not the case. This is the situation. We don't have an exhaustible amount of money, and the medications are expensive, and availability is in question most of the times, especially in times of need, and the medication have a lot of side effects. This is the cost in the US. I try to get the cost in our hospital, but the bureaucracy prevented that. But it costs billions in the US. It costs millions in here. And they have side effects. Compared to the regular conventional synthetic methotrexate, DMARD, methotrexate, or Leflu, or others, they cost a lot. And they have also side effects. They have no serious, because the regular synthetics have small or no increased risk of side effects. This is supposed to show, but it doesn't show. أنا شريتها ب5 ريال. المهم واضحة هناك. والbiologics, they have a lot of serious infection ranging from 3 or 7 per 100 patients here, no major differences between the classes, and they are higher during the start period and increases further 5 or 3-fold after the first one. JAK inhibitors are no different from this, and they have their own serious infection ranging to the same amount of the other biologics, and no major differences between the different 3 approved JAK inhibitors. So what do we do next? Then we can continue the same dose, and with its entailing cost, availability, increased side effects, or taper. But is it effective and cost effective if we taper these medications? And do we taper biologicals to lower dose or stop the dose? And if flares come, then we go back to the original dose, and or taper biologicals and persist in using conventional synthetic DMARDs. This is the first study. This is using 25 milligrams per week etanercept. Initially, when etanercept was introduced, it was introduced as 25 twice weekly. And then they increased the gas. They make one single dose of 50. So this is going back. What they did here is basically they took the patients who achieved remission or low disease activity and randomized them to once weekly 25 or twice weekly 25, which is basically 50. And this is basically what happened. The once weekly 25 in 159 patients did so good. They remained in remission from around to 70 to 80%, up to 7 years. So this is not bad, especially if we know that from the data Dr. Hanan presented yesterday, this is actually in the range of an extreme. And also the radiological changes were not worse than the 50. So if we look at the slides, the ones which has the modified total sharp score, the 0 mark makes no changes, or marks no changes. No difference between 25 and 50 in the first year and also in the second year. And the the percentage of continuing the 25 medication is similar, if not better than those with 50. Yeah, this is good, but this one is not good. It doesn't shine here. So I'll stop using this. But you see from the graph that the light gray is the 25, and this actually is above the dark black. And the risk of infection is much reduced in the group A compared to the group B. And there was a lot of also treatment cost saving, with actually saving in that study about 3 million and so euro, not even reals, euro. And it still continues to produce saving every year. This is 25 milligram in RA and spondyloarthropathy. And if you see from the graphs that the 25 did much, even slightly much better than the 50 in DAS score and also in the BASDAI score. So the conclusion was obvious from those graphs, but that there was a strong improvement in the half dose compared to the full dose. And this is also 25 in psoriatic, in rheumatoid, and ankylosing spondylitis. The ankylosing spondylitis response was excellent, actually 100%. Less so in the rheumatoid arthritis with 70%, and even less in psoriatic arthritis. And there was also a total saving over 7 years with 622,000 euros. And it saved also money to buy extra 25 extra treatment to treat 25 extra patients for 1 year. This is actually, even from my own experience, is applicable. This is a bigger study where they have 200 in each group, those who had the full dose, which are marked in blue dots, and the 25 milligrams dose in the red triangles, and the other one in the bottom is the placebo. And it showed that 25 is similar in response to those with 50, with no change. This is patients achieving remission. Another study showed also similar effect. In early RA, remission on full dose methotrexate reducing the dose did not cause a significant worsening of PRO, which is the patient-reported outcome. This is adalimumab. That was etanercept. This is adalimumab. And in their conclusion, it was 2/3 of tapered remained in remission, tapering the adalimumab. They actually, instead of 2 weeks, they made it into 3 weeks. The dose, the same dose, but 3 weeks. And half of withdrawn, those are which discontinued the adalimumab altogether, stayed, a third of half of them remained in remission for a total of 36 weeks, which is basically more than, just less than a year. And again, with rituximab, the picture is repeated again with only 9% failure and relapse, and 91 responded. What they did here is they reduced the dose from 1 gram, which is 1,000 milligram, to 500 instead. And I even remember in EULAR a few years back, some people even tried 250, and it was also producing effect. This one also showed a similar picture, that a third patient with RA and with low dose remission may taper biologic or stop biologics. This is general, basically dealing with many drugs, not just the ones I mentioned before, but many other drugs. And the other conclusion was that the dose reduction of TNF blockers may be non-inferior to continuum full dose. So how about discontinuation? We noticed from those previous studies, some of them actually discontinued, not only tapered, but discontinued. So this is also a mixed bag of many drugs from the biological categories or the small molecule categories, where they basically took 46 patients with on an anti-TNF treatment basically with rheumatoid arthritis, 19 with tocilizumab and 32 with tofa, and they discontinued them. Some of them dropped out at the initial start of the stages of that trial. But the first curve on the left showed the cumulative incidence of flare. So this is not remission graph, it's flare graph. And actually, after 4 years of trial, there is around 50% remaining in remission. And if you go to the right curve, the green one is the tofa. It's the one which actually rebounds again. So the more flares after discontinuing tofa than with the tocilo, and better even still with the anti-TNF. So anti-TNF remains in the system more, or remains continuing its benefit for more years than the other one. And this is quite a long number of years. Look at the 6 years, 5 years, etc. At least you could save a lot of money in those initial years, the 2 years, etc. And you can, if you need to restart, start after saving money and also side effects. And the final point here was radiological progression is rare for at least 3 years. So both clinical and radiological remission. This is a 10-year study, and their conclusion is basically tapering is a long-term option in RA patients on biologics and low disease activity. And there was only 10% flare at 6 months, and 20 at 12 months, and 50 after 5 years. So 50 after 5 years is better than what Dr. Hanan said yesterday about our data here. Although most of the drugs will remain 60 or 70 in remission. Another one, which is also a long-term study, showed reducing anti-rheumatic drugs in patients with RA in stable remission is feasible, and the maintenance of remission occurring in about half the patients. This is in daily practice study and showed the same. But they also added that the combination of biological with methotrexate could improve the success of dose reduction attempts. So this is stressing again on maintaining the conventional synthetic DMARD plus your reduction in your biological DMARD. And the cost saving is quite significant. Look at the ones which are marked or squared in blue, and you see that adalimumab, half or 50% reduction, and the same with etanercept, and again with rituximab. So there is a lot of saving here, in addition to saving the side effects and maintaining. EULAR also agrees with it, and they say with the sustained remission, DMARD may be tapered. طبعا هم حطوا الكلمة الأخيرة اللي أنا كتبتها بالgray, but I am saying that it may be also stopped, and you can go back. You're not losing a lot. And the levels of evidence was for the agreement was high. How about tapering biological DMARD and staying on synthetic or conventional synthetic? That was obvious from the previous ones. And this study confirms that or argue for that. And it actually shows, if you look at this curve, you see the tapering anti-TNF in the light gray, and the black is the tapering of conventional synthetic. And the conclusion is up to 9 months, flare rates of tapering conventional SMARC or TNF inhibitors were similar. Even after the 9 months, the 12 months, there's still overlap between the two periods. And they also add this, that from a society perspective, it would be feasible or more sensible to taper TNF inhibitors first because of the cost saving. And from the start of the therapy, if you want to treat a patient with rheumatoid, don't rush don't rush into biological straight away. Give the conventional synthetic enough time and enough dose for it to work. The difference between the two is only minute, yani. This is the TEER trial. This طبعا was not sponsored, and it actually came from NIH. There was no difference in DAS28 ESR between participants randomized to methotrexate plus etanercept or triple therapy, methotrexate plus sulfasalazine and hydroxychloroquine. Although some people argued that there was a little bit of progression in radiological, but it wasn't all that significant. And the graphs are here because they had 4 arms for the study, and they are running parallel. And this is even before that, the BEST study, the famous BEST study, showed similar results. That the combination, either the combination with prednisolone or initial combination with infliximab, showed more reduction in the DAS and HAC than the sequential or cycling of monotherapy. So these are my conclusions and recommendations. Tapering is effective and saves a lot of money and reduces side effects. Taper or reduce dose to the least effective dose. If the medication was stopped for any reason, either the patient is not coming to the hospital or lack of medicine, do not rush into restarting. Watch and see. If you need, recommence. If not, leave them alone. And as we said, before starting all biological agents, please persist longer with conventional DMARDs in maximum doses, as in TEER study and previously in the BEST study. And we try to taper biological before the other, and you're not losing a lot. You can go back if you taper and flare. Wassalamu alaikum wa rahmatullahi wa barakatuh.